Everyone, iTech welcomes all the participants for today's special National Distance Learning Seminar series. Today's topic is recent updates in ART and speaker is Dr. Rewari. Dr. Rewari is a former Associate Professor of Medicine at Postgraduate Institute of Medical Education and Research, Dr. Ram Manohar Lohia Hospital, New Delhi. He is a clinician turned public health specialist who has actively contributed to the national ART program in India for the last 12 years as WHO National Consultant earlier and later as National Professional Officer ART at WHO Country Office India before moving to his present position as Scientist HIV/AIDS at WHO CRO. He has published nearly 80 articles in scientific journals and books and has edited 2 books on HIV/AIDS. He is recipient of Best Teacher Award from DMA, Best Allopathic Physician Award, GB Jain Oration, Ranbaxy Oration from IMA, PJ Mehta Oration in 2013 by Association of Physicians of India and was awarded Fellowship of Royal College of Physicians, Ireland in 2010. We welcome you, sir, for today's special NDLS session.
Good afternoon, members of the team CST across the country. It's my pleasure to be with you again on this important NDLS. As you are aware, India has taken a big leap ahead in providing antiretroviral therapy across the country by once again revising its guidelines in line with the recommendations from WHO and available scientific basis. This move by NACO will definitely be a step forward in moving ahead towards the target of 90-90-90. I hope you are aware what is 90-90-90. So in this session today we'll be learning what are the revised guidelines on initiation of first line ART. We'll be focusing specifically on the first line ART in this session. The second line, third line ART basically have already been dealt in part and will be dealt in subsequent sessions. In this session I will also try to answer questions, comments and concerns about new treatment guidelines. Yesterday an email was sent to all centers basically to give their own questions, concerns they have on this new recommendation, and we received a very good response, and I have tried to compile all those questions into a question answer session because it is very difficult in 1 hour to take up all questions, read questions as you type. So my request at the beginning to all of you is, let us go through the presentation first. Then in the second part of presentation, I already have answers to questions which came from the ART centers. I have compiled them into question answer form because if you start typing questions now, many of these will already be there and that might be a duplication of the effort. So let me start with very basics of antiretroviral therapy. You have seen this office memorandum. This is a memorandum from Deputy Director General, Care Support and Treatment, dated 5th May 2017 on recommendation of treating all pale HIV regardless of CD4 count, clinical stage, age or population. So starting with basic, we know that antiretroviral therapy is a combination of at least 3 drugs from at least 2 different classes of antiretroviral drugs, and this therapy is basically given to those infected with HIV to achieve maximal and most durable suppression of viral replication. When we say maximal, we want to suppress the viral replication to below the level of detection by currently available tests, and most durable means for as long as possible. With this suppression of the viral load, there is a restoration of the immunity, there is an increase in the CD4 count, there is decrease in the reduction in the number of opportunistic infection, and definitely leads to improval of the quality of life as well as survival. Also, it is very important to suppress the viral load to prevent the emergence of drug-resistant mutations. We know what are the goals of antiretroviral therapy. Many of the initial slides will be a repetition of what you already know, but some of the new ART centers, MOs, might have joined and might not have undergone training, so I have kept some initial slides for benefit of those people who have joined late into the program. So antiretroviral therapy basically leads to a greatest possible reduction in the viral load, which leads to immune reconstitution, that is both quantitative and qualitative, and this ultimately leads to improvement in quality of life. What is very important in antiretroviral therapy is a rational sequencing of drug. what we call as first line drug, second line drug and third line drug, because we want to maintain the future treatment option of a person who is failing on a particular line of treatment. We also want to limit the drug toxicities and facilitate adherence by providing most robust first line antiretroviral therapy. Antiretroviral therapy, as you know, also reduces the viral load, so it also helps in reduction of HIV transmission by suppressing the viral load. Can we eradicate HIV? With the currently available treatment available to us, the eradication of HIV is not possible. Hence, even the cure of antiretroviral therapy, cure of HIV infection is not possible, because even when your viral load is suppressed to below detection level, still there is evidence of genetic evolution of the virus in the reservoirs. And what are these reservoirs? Some of these reservoirs are basically in the brain, in the gut, lymphoid tissue, in the spleen, in the lymph node and bone marrow. And these potential reservoirs include T cells, macrophages, tissue compartment like gut and brain that contain these cells. So, when we cannot eradicate the virus, can we stop the antiretroviral therapy? Because this was one of the questions that came from the field. No, we cannot stop antiretroviral therapy because we cannot eradicate the last virus particle from our body. So, eradication is not possible. This has been seen by a strategy called structured treatment interruption, where the treatment was stopped after the viral load was suppressed to below detection level, but the virus reappeared in the body. That shows that if you stop antiretroviral therapy, the virus will reappear. And HIV cure is still far away, though there has been a progress in this regard, but a HIV cure which is practically possible is still far away. So coming to basics of antiretroviral therapy, I think you must have seen, most of you, this slide number of times. This is basically how antiretroviral drugs act. Basically, as the virus gets attached to the T cells, CD4 T cells, through GP120 receptors facilitated by CCR5 co-receptor or CXCR4, it enters the virus, the CD4 cell, whereby the RNA is released, and this RNA is converted to DNA by an enzyme called reverse transcriptase inhibit, and this double-stranded DNA is then integrated basically into the host genome by another enzyme called integrase. Then this multiplies and produces the virus-like RNA, which then bud out of the cell facilitated by another enzyme called protease. Basically, this antiretroviral therapy, you can understand, is like a car assembly line, whereby a car is assembled at different point on a strip which is going along. At certain point of the time, the body is put up, engine is put up, wheels are put up, and then the finished body comes out. So similarly, in HIV replication, you have got different enzymes which facilitate this process, and if you are able to block these enzymes, the replication will stop. So a finished product will not come out. So these enzymes we can use, that we can block the fusion of the virus with the CD4 cell. We can block reverse transcriptase enzyme, drugs called reverse transcriptase inhibitors. We can block integration, drugs are called integrase inhibitors. We can block this budding out of the virus by suppressing the enzyme protease. So drugs are called as protease inhibitors. Accordingly, the drugs are, I'm sorry for this, and the drugs that are available are classified into different groups. That is reverse transcriptase inhibitor, which can be nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and then CCR5 entry inhibitors and protease inhibitors. Basically, presently we are using a combination of either a nucleoside or nucleotide reverse transcriptase inhibitors with non-nucleoside reverse transcriptase inhibitor, and we use protease inhibitor, preferably in the second line, or if NNRTI cannot be used. The drugs which are marked with asterisks are available in the program, and certain drugs have been phased out and are no longer used in antiretroviral therapy anywhere. So what are the national revised guidelines on antiretroviral therapy? Guidelines have been changing over the years, right from 200 to 350 to 500, treat all. How these guidelines change over the years? These guidelines basically are changed depending on the availability of new evidence, and new evidence can come from different sources, but the most robust new evidence that we get is from randomized controlled trials. Randomized controlled trials are trials whereby you have two arms, and in one group of patient you give early antiretroviral therapy, another group you give standard therapy, then you compare the outcomes in both the arms in terms of progression to AIDS, in terms of opportunistic infection, particularly the occurrence of tuberculosis, and then based on that evidence the recommendations come. So right from 1995 antiretroviral therapy became available till now, there have been number of trials which have been actually responsible for giving us the evidence that guidelines keep on changing. In details of these trials, basically the CIPRA trial, SMART trial, HPAT-1052, Temprano trial and START trial, all these have been discussed in earlier NDLS, basically on 5th July 2015 and 20th July 2016, and will be available to you in the recorded session. I will not go to details of these trials for the want of time. But all these trials have given a very clear evidence that there are definite benefits of providing early antiretroviral therapy in terms of reduction of the mortality, decreased T cell activation, reduced markers of inflammation, reduced risk of liver disease progression, and when you start antiretroviral therapy early, the immunological response is more robust, and also it prevents the transmission of HIV by suppressing the viral load. So over the years, the guidelines have been evolving towards earlier initiation. You start early, you start with simple treatment, single regimen that follows a public health approach. You start with less toxic, more robust regimen. Over the years, this has been changing, and you have better and simpler monitoring tools over the years. Now, basically, what is the need for ART initiation in all PL HIV? The recent trial, particularly the Temprano trial and the START trial, have shown that there is a definite reduction in the incidence of opportunistic infection, specifically TB, because the TB is the commonest opportunistic infection among PL HIV. It reduces the mortality and improves the health-related quality of the people. So, NACO in May 2017 revised the guideline on when to initiate ART, and very clearly it says that all persons diagnosed with HIV infection are eligible for ART initiation, regardless of CD4 count, whatever be the CD4 count, or clinical stage. It may be clinical stage 1, 2, 3, 4, any age. It may be a child, it may be adult, it may be adolescent. Population, it may be a pregnant woman, it may be a serodiscordant couple, it may be a key population like female sex worker, MSM, IDUs. So all persons diagnosed with HIV are eligible for ART initiation regardless of CD4 count, clinical staging, any age or population. So the algorithm has been simplified. Any clinical stage, adult and adolescents, more than 5 years, children more than 5 years, treat all regardless of CD4 count after baseline clinical assessment and preparedness. This is very important, and I will discuss this more in detail later on. Children below 5 years again start irrespective of the CD4 count, regardless of CD4 count or clinical stage. All patients in pre-ART care who are currently with us, they should undergo a fresh CD4 test, undergo a baseline investigation, at least 2 sessions of preparedness counseling, as we do for new patient. All new patients who are registered basically have to undergo all these investigation and 2 sessions of preparedness counseling. This should be done for patients in pre-ART who are not on ART because the CD4 cutoff was more than, they have CD4 of more than 500. So what are the consideration? All people who are with HIV, confirmed at ICTC, should be registered in HIV care. They should be registered in pre-ART. Even with current guidelines, please be very clear, even with current guidelines, on treat all, pre-ART registration has to be continued. All these patients are eligible for antiretroviral therapy, but they must undergo a comprehensive clinical and laboratory evaluation. We must look for pre-existing opportunistic infection. They should undergo preparedness counseling. ART should be started only when they are prepared. All are eligible, but preparedness counseling is very important. Last week, Dr. Anuradha from Maulana Azad Medical College Center of Excellence had taken a detailed session on workup of HIV positive patients, so I will not go into those details to save time for future further interaction with you. So basically, like any other patient, the first step is a clinical history. We should look for HIV specific symptoms in the past or present. Also look for past history of TB, sexual history, personal history, family history of TB, any history of ARVs in the past or blood transfusion. We should also look into the behavioral psychosocial assessment of the person, what is the education level, what is the employment status, what is financial status, because these are going to affect his adherence. We should also identify a primary caregiver who will be responsible for adherence of the patient and providing support to the patient if he gets sick. We also need to do a nutritional assessment and provide nutritional counseling and supplementation from different schemes of Government of India. The next step is a good physical examination to see for weight, height. Very important to see the response to therapy, for the dosages of the drugs. We look for oral cavity, lymph nodes, look for fungal infection in oral cavity, see for lymph nodes, systemic examination, all those parts that are part of a good clinical examination by any medical officer. Then patient has to undergo certain tests, laboratory tests. These are important for clinical staging. These are important to rule out opportunistic infection. These are also important to see the baseline health parameters, baseline fitness of the person. And these include, first and foremost important is CD4 count, the hemogram, urine for sugar and albumin, fasting blood sugar, creatinine, ALT, VDRL, X-ray chest, pregnancy test if required, and other symptom sign directed to identify opportunistic infection. Mandatory test every person must undergo before initiation of ART. However, there are certain additional tests which physician would like to see depending on the patient's presentation and opportunistic infection. But when we say all patients should undergo this investigation, it is very important that effort should be made to fast track this investigation so that ART initiation is not delayed. There are certain tests which are for special situation like surface antigen for hepatitis, anti-HCV antibodies, and for patient to be initiated on PI based regimen, baseline blood sugar, LFT and lipid profile are to be performed. The step 4 is the most important step, that is the preparedness counseling. ART is not an emergency intervention, though we would not like to delay the benefits of antiretroviral therapy, but still person has to accept that he is positive. We have to see his opportunistic infection. He has to understand it is a lifelong treatment. He has to be ready for this treatment adherence. While he is on treatment, he has to understand that even while he is on treatment, while his viral load is suppressed, he still needs to adopt safe sex and positive prevention methods. So the basic principles of consideration before ART initiation are: this treatment should be based on person's informed decision. It should be preparedness. He should understand the treatment. Caregiver should be identified. Caregiver should also be counseled. Also, remember, all patients with CD4 less than 350, even when it is treat all, should be started on CPT. It is very important for patients' education to understand that ART is not a curative. It is a lifelong treatment. I think some of the medical officers also wrote to me, if it is more than 500, can you start ART and stop later? No, you cannot stop antiretroviral therapy. It is a lifelong therapy with good adherence. Patient have to understand that there will be some short-term side effects, there could be some long-term adverse events. He has to be prepared for that, and he has to understand that safer sex is still essential. Also, before initiation, all patients need to be screened for TB, because TB is the commonest opportunistic infection. I think you all are doing this. You know the 4-symptom tool, that is current cough, fever, night sweat, weight loss. And if you have any one of these, the patient needs to be fast-tracked for TB diagnosis using CBNet, that is cartridge-based nucleic acid amplification test, what is commonly called as Gene Expert. And now all ART centers are linked to some Gene Expert machine for tuberculosis diagnosis. But if these 4 symptoms are not there, then we can reasonably assume that person does not have active tuberculosis, so he needs to be provided isoniazid preventive therapy to prevent tuberculosis. Also, we have to remember that ART should not be started in presence of active OI, and OI should be treated before this. I will skip through some of these slides because these were dealt in detail. Again, if there is any undiagnosed active infection, diagnose the OI. TB, very important, start TB treatment first. ATT now is provided from the ART center itself. ART-MO is authorized to give anti-tubercular treatment. So start TB treatment, start ART as soon as possible, after 2 weeks but before 2 months, at the earliest when the patient is stabilized on ATT. But for those group of patients who have got CD4 less than 50, start ATT first, but then start ART within 2 weeks of ATT initiation. But you have to monitor more closely for the clinical as well as laboratory monitoring for the side effect, because we are using ATT and ART within a short span of 2 weeks and there are overlapping toxicities. Also, if there is person is diagnosed with pneumocystis carinii pneumonia, start treatment first, start ART when PCP treatment is completed. Similarly, treat esophageal candidiasis first and then start antiretroviral therapy. Again, there are guidelines basically on different opportunistic infection, and you can go through these from the last lecture also. What is very important is for cryptococcal infection, we start ART. For cytomegalovirus, since it is very important because the person may get blind very quickly if treatment is not started for cytomegalovirus, then we start treatment of cytomegalovirus urgently. It is a drug listed in the OI list and drug has to be procured by the ART center from the contingency money. For the money, 50,000 provided for opportunistic infection, and start ART after 2 weeks of the treatment. So once we have decided to treat the person has been adequately prepared. What ART regimen? The ART regimen remains unchanged. For those with HIV-1 infection, we use 2 NRTIs, 1 nucleotide reverse transcriptase inhibitors, that is tenofovir, then 1 nucleoside reverse transcriptase inhibitor, lamivudine, that is 2 drugs from NRTIs, and 1 NNRTI, that is efavirenz. So the preferred regimen for all patients to be initiated on ART is tenofovir 300 mg with lamivudine 300 mg, efavirenz 600 mg, 1 tablet daily at bedtime. Some of you may be finding this is just a repetition, but it is just to recapitulate your knowledge and to inform you that this remains the preferred regimen even with the treat all guidelines. Because we are using this regimen because this is the most robust, least toxic regimen, most well tolerated, available as single tablet in a fixed dose combination of 3 drugs. It is easy for patient to take, and if you have to take 1 tablet compared to 3 tablets, the adherence with 1 tablet will definitely be better, because people tend to forget, particularly as they become better, they tend to forget. This regimen is given now for all adults, all adolescents, pregnant women, those with HIV TB, those with HIV hepatitis co-infection. Also, it is safe in pregnant, is effective against hepatitis B virus. So this is the regimen for all new patient to be started on antiretroviral therapy. But if there is a HIV-2 or HIV-1 and HIV-2 co-infection, then instead of NNRTI, because your NNRTI, both nevirapine as well as efavirenz, are not active against HIV-2 virus, so the preferred first line regimen in such cases will be NRTI of tenofovir lamivudine with a protease inhibitor, basically lopinavir ritonavir. So to summarize the first line ART regimen, tenofovir lamivudine efavirenz is the first line ART regimen. Please be very focused on this for all ARV naive patients. Naive means those who have not been exposed to antiretroviral therapy in the past, except, this except is very important, this is new introduction, except those with known renal disease. If there is evidence of renal disease in the person, then we cannot use tenofovir based regimen. We cannot also use tenofovir lamivudine efavirenz for HIV-2, HIV-1 and 2 co-infected, or women with single dose nevirapine exposure in past pregnancy, because these HIV-1, 2, 1 and 2, HIV-2, HIV-1 and 2 will not respond to efavirenz and they will be virtually on 2 drug if we use this regimen. And also women with single dose nevirapine will have archive resistance to nevirapine and cross resistance to efavirenz. So tenofovir lamivudine efavirenz is the preferred regimen for all ARV naive patient except those listed here. If person has got a known renal disease, then we use abacavir lamivudine efavirenz, because tenofovir has got a renal toxicity which abacavir does not have. So we use abacavir lamivudine efavirenz. If a person has got HIV-2 or HIV-1 and 2, or if there is a pregnant woman who has been exposed to nevirapine, then we use tenofovir lamivudine lopinavir. Again, to reiterate the old guideline, all patients who are either on zidovudine lamivudine efavirenz or zidovudine lamivudine nevirapine initiated earlier in the program need to be continued on the same regimen. The regimen should not be changed. So the general guidance is a single pill of TLE taken at bedtime 2 to 3 hours after the dinner. Fatty food to be avoided because fatty food increases the concentration of efavirenz and the toxicity may increase. Patient with severe diabetes and hypertension should be monitored more closely. Now coming to age and weight. Since we don't have 150 or 200 milligram formulation of tenofovir, so all adults, adolescents who are weighing less than 30 kgs should be monitored more closely because they have low body weight, and low body weight is a risk factor for tenofovir toxicity. So if their weight is less than 30, they should be monitored more frequently for the toxicity. Again, cotrimoxazole prophylaxis, very clearly in treat all, whatever with the CD4, you initiate treatment, but CPT you provide on the same if a person has got CD4 counter less than 350 or he has got clinical stage 3 or 4. That is the primary prophylaxis, and secondary prophylaxis if they have completed treatment for PCP and toxoplasma. And basically we start cotrimoxazole prophylaxis first and initiate ART 5 to 6 days as soon as the CPT is tolerated, there is no skin rash, and meanwhile the patient has completed the preparedness phase. The dosage is 1 double strength, that is 800 milligram and 160 milligram, or 2 single tablet strength basically. And when we stop, once the CPT has been initiated, we stop only when CD4 is more than 350 on at least 2 occasions done 6 months apart, and there is no clinical stage 3 or 4. There was a question, if we don't have CD4 count available, how do we start CPT prophylaxis? If a person has got clinical stage 3 and 4 disease, the prophylaxis should be started. So the checklist is person should have undergone counseling, adequate preparedness counseling, there should be correct residential proof, identification of a caregiver, and consent form should have been signed. Again, to summarize, before I go on to the questions, key points are NACO treat all. Treat all is a concept, it is a guideline. It means all persons diagnosed with HIV infection are eligible for ART initiation regardless of CD4, clinical stage, age or population. But, there is a but, all such people should be referred to ART center for registration, comprehensive clinical evaluation, treatment of opportunistic infection, treatment preparedness and timely initiation. Remember, this does not change with the treatment guideline, treat all guideline. Continued treatment adherence is very important as the person is started on ART. So, again to re-emphasize, treat all means provide ART irrespective of their CD4 count, viral load values, but it does not mean initiating ART immediately after getting a HIV positive report or same day initiation. I will clarify further. There is a difference between treat all and test and treat. What is being given in field, some of the impression I have seen even in a newspaper report from one of the states, that test and treat, as soon as person is found positive, treat. Yes, it is for good, okay for a layman, but for a provider, healthcare provider at ART center, it does not mean that. Very clearly it does not mean initiating ART immediately after getting a HIV seropositive report or same day initiation. Start ART only when patient is ready. But what is important with treat all now is effort should be made to reduce the time between HIV diagnosis and initiation. Earlier we used to say it should be 15 days. We used to give CPT for 15 days, see the adherence with CPT, see the toxicity, and then start ART. That was way back in 2005 and 6. Now, effort should be made to have a minimum time. Minimum varies from person to person. It may be 5 days for one person, it may be 10 days for other person. It depends on patient's preparedness, patient's understanding of the disease and ready to take treatment. So what could be the possible challenges? When we NACO rolled out this, there were different challenges that were there in the field, and these could be programmatic challenges, technical challenges and viral challenges. Challenge was we need to identify people early. People are still coming with very low CD4 count. How will people access? There were concerns over overloading the facilities, retention of the patient, issues about supply chain for antiretroviral drugs and affordability, whether we can afford these drugs for additional number of patients. So these challenges were identified and some recommendations were made, and I will quickly go through them. Late presentation, still most patients come with low CD4 count. Late presentation partially nullifies the advantage of treat all, because if you are identifying late, the mortality will be more, transmission might have happened to others, but there are many missed opportunities in people who come with late low CD4 count. So it is very important that training of healthcare providers, private sector involvement, and education on risk identified by the patient. There should be a IEC campaign that patients are able to identify their own risk perception, that they might have this risk, I might have HIV, I need to go for HIV test. Inadequate counseling, testing services. Loss of patient between cross referrals from TB to STI to ICTC, ANC to TB clinics to ICTC for testing. So some of the suggestions were community-based testing, use of rapid diagnostic tests. WHO also recommends self-testing and also provider-initiated testing and counseling. One challenge was that ART is available at mostly at standalone centers, which are at tertiary or secondary level of healthcare, and people have to travel distances. So recommendation was to decentralize ART to more LSCs. There is a linkage loss from testing site to ART center, 18 to 20%. So it was recommended that there should be unique identifier at ICTC. As soon as a person is identified, you should be provided with a unique identification number, so that he is not lost in the follow-up. Overcrowding at ART site. What would be the overcrowding? It will be 12 to 15% increase. It will not be a massive increase. It will not be a sudden jump. People will come gradually as they come to know of this. So different things were suggested for this, to increase the number of LSCs, to have dispensing for 2 months, 3 months, have differentiated care model whereby stable patient do not have to see doctor every month. Inadequate counseling opportunities, because as the load will increase, the counselor will be under more stress, so quality of counseling may go down. So it was recommended to identify priority population. Asymptomatic patient with higher CD4 count should be given more time for counseling at the time of initiation and in the initial few months after initiation. High LFUs, particularly persons who are asymptomatic, they are more likely to be lost to follow-up because of their poor understanding. They don't have any symptom. So it was important that we should follow retention cascade at regional level, district level, facility level, utilize SMS based reminders, reduce the distance patient has to travel, and provide adequate counseling. Funding has been decreasing, as most of you are aware, but there is a need for increased domestic funding, and our health ministry has committed to provide all the funds that are required for this scale up. There are other challenges which come as we move towards treat all. We need to do routine viral load monitoring. Drug regimens may get complicated over the time because patients have been exposed to multiple NRTIs in the past, stavudine, benzidovudine, now tenofovir, and they are failing on those. Monitoring and supervision is important, and regular sensitization of healthcare providers is also important. And we may have challenges in terms of emergence of drug resistance over time, and we may have future limited options for cases of drug resistance which we are seeing now. But treat all is doable with decentralized service delivery, expansion of service delivery, giving drugs for more than 1 month, involvement of community, involvement of care and support centers as LSCs in providing drugs, having a robust supply chain, and care support and treatment team at NACO has developed an India-specific model of differentiated care whereby stable patients do not have to come to health facility every month, and there is a focus on the cases with advanced infection. So that was a brief overview of the treat all. As I told you, we received many questions from the facilities yesterday and today morning also, and I have tried to compile them into questions, and if there are questions which are not answered after this will be another 15 minutes, so we will have another 10 to 15 minutes for taking up your questions again. Most important question: what is the difference between treat all and test and treat? There is no standard definition as such, but what we understand that treat all is a guideline. It is a guideline that we need to provide treatment to every HIV infected person. Test and treat is an approach that we test a person and provide him antiretroviral therapy. Treat all, I will read, treat all implies person should be initiated on ART regardless of CD4 count clinical stage, while test and treat implies more rapid accelerated initiation of ART as soon as a person is found positive. This is to prevent loss to follow-up or if CD4 count facilities are not available. But remember, India has adopted a treat-all approach. NACO has adopted a treat-all approach which includes providing treatment to all HIV infected but with proper clinical evaluation, laboratory evaluation, proper treatment, preparedness, management of opportunistic infection in a holistic manner. This policy is applicable for all ages. It is less than or more than 15. There was a question, shall we wait for instruction from SACS to implement it? No. The OM sent on 5th of May 2017 from NACO is sufficient. However, SACS have to ensure proper dissemination and implementation, because I have come to know many ART centers still have not received this office memorandum. Another question was, some of the ART center ART initiation is put on hold till baseline investigations CD4 reports are available. As I have said again, this baseline workup is important to rule out opportunistic infection. We have to look at the person infected with HIV in a holistic manner and not just provide ARV drugs. If he has got an opportunistic infection like cryptococcal meningitis, like PCP, like toxoplasmosis, like cytomegalovirus, it needs to be treated first. And once the induction phase, initial phase of treatment is complete, only then antiretroviral therapy needs to be started. So a baseline work is important. However, in some situation, if there is a long delay, that was came from Northeast, if there is a long delay in CD4 report, one can take the sample, initiate ART after ruling out opportunistic infection with proper preparedness counseling. But that should be a exceptional situation rather than a routine situation. Another question was, pre-ART number should be registered. Yes, all patients should be registered in pre-ART care because they may not be on immediate ART. There may be some opportunistic infection, cryptococcal meningitis, which call for delaying ART till the induction phase of meningitis is treated. Some patient may not be prepared to take ART. They don't understand. They have difficulties in coming. They don't want to start. So all patients should be registered in pre-ART, and if not initiated, the reason should be clearly documented in the pre-ART register. Again, this was a very important question. Should we increase all follow-up pre-ART patients? There are suppose 1000 patients in pre-ART. They become eligible but not on ART. So they ask, how do we change this in the monthly progress report? You need not change. Don't attempt to initiate all pre-ART in 1 month. Do not add this to eligible and not initiated. Though they are to be initiated, as and when they will come to know of the guidelines or as a routine when they pay a visit to ART center. People who are in pre-ART should undergo a fresh CD4 count because this recent CD4 count will be their baseline count at time of starting ART and will be important to see for their response to antiretroviral therapy or for the immunological failure. So do not attempt to start patients suddenly, and they should not be called eligible not on ART, but again over a period of time, yes, these need to be tracked as once the system is stabilized. Should we call patients in pre-ART care and who are now eligible? No. We don't want to overload the system suddenly. Presently initiate as and when they come to know or pay a routine visit for their repeat CD4 count. But all new patients who are now being registered and should be provided antiretroviral therapy. But once the system is stabilized, maybe over 2 months, 3 months, varies from center to center, we need to track these patients also who are in pre-ART care because they had a higher CD4 count, and we need to start them on ART. Okay, another question are, what should be average time for registration and initiation and how many prepared sessions are required? You know, again it depends on the patient's profile, his educational status, his opportunistic infection, his understanding of ART, his willingness to take ART. So at least 2 to 3 sessions are recommended. The 2 to 3 sessions of preparedness counseling should be done. And this can be done in a period of 5 to 7 days. And this is the period when patient has come to ART center, registered, given samples for baseline investigation, CD4 count, and is awaiting his report. So this time can be utilized for preparedness counseling, and only then treatment should be started. If CD4 kits are not available, what to do with the patients in pre-ART care? CD4 test done 3 months and now CD4 facility not available and CD4 is not continuously available. We are not calling patient proactively in the beginning, but ultimately we will have to follow them, call them, repeat their CD4 count and for their baseline count. It is not for eligibility. Doing a repeat CD4 count is not for eligible because everyone is eligible irrespective of CD4 count. So they need to be called over a period of time. What should be frequency once the CD4 testing person is on ART? It remains the same. Essentially, every person on ART should undergo CD4 testing at least every 6 months, more frequently if required, depending on patient's clinical condition and the judgment of the medical officer. Once the viral load becomes available, the guidelines have been drafted, it is not still available, but once viral load is available, person is virologically suppressed and his CD4 count is more than 350, then CD4 testing can be stopped. But that is a thing of future once you have viral load monitoring available for all patients. In test and treat, there were concerns raised that people will accept the treatment initiation, initially fear because they are HIV positive, there is a treatment available, but since they are asymptomatic, they will basically stop treatment, become LFU, contribute to drug resistance. Yes, this is a possibility, this is a theoretical possibility, particularly when you have a higher CD4 count. Any person who is sick takes his treatment regularly, and as he becomes better, the chances of default become higher, and this you can correlate with yourself. If you have got a diarrhea, how many people take a course of Metrogyl 3 times a day for 5 days? Hardly any healthcare provider, unless he continues to be sick. So it is very important to focus on patient with higher CD4 count and counsel them adequately and properly, and this is one of the group of patients who should be basically focused more. Only TLE is to be used? Yes, TLE is the preferred first line regimen for all ARV-naive patient, not AZT based regimen, except those who are with known renal disease, with HIV2 or 1 and 2 co-infection, or women with single dose nevirapine exposure. AZT based regimen are to be used only for existing patient or for those where TDF and abacavir cannot be used. TLE regimen dosage age wise, weight wise. We will be using TLE only for adults and adolescents who are more than 10 years of age and more than 30 kg of weight. But if they are more than 10 years of age and weight is less than 30, will still get TLE, but these people will have to be monitored more closely for tenofovir toxicity. CPT. Is CPT required as chemoprophylaxis? Shall we start or not? At what CD4 count? And in absence of CD4 test, how to decide? These were the questions that came from people. Commencing primary CPT guideline, I have already emphasized on this, that you start CPT in patient with CD4 less than 350, clinical stage 3 or 4. Primary CPT, give one double strength tablet once daily. Stop when CD4 is more than 350 on at least 2 occasions, done 6 months apart, or there is no clinical stage 3 or 4 illness. Criteria for treatment failure have changed? No, there is no change in the treatment failure criteria. You should suspect a immunological failure if the CD4 count falls to baseline or below, or persistent CD4 below 100 cells, or there is a 50% fall from peak on treatment value. There was a question from a particular person that he had problem in getting a alternative regimen of drug when he had a side effect of tenofovir, and he was asked to come again after 3 months. No, there is already a mechanism of State AIDS Clinical Expert Panel and National AIDS Clinical Expert Panel. This mechanism exists already to take care of such cases. Lot of questions came that number of patients will increase, pharmacist work will increase, counselor work will increase, so we should be given more staff. Yes, there will be increase in the workload, definitely. This will be gradual. Yes, pharmacist will have more work, counselor will have more work. So this has already been thought, and multiple modalities has been actually thought of, which will be implemented over coming months. Having more link ART centers, having more facility integrated ART centers. Also, basically, there would be ART center started in all those districts where there is no ART center. Almost 230 districts do not have ART center. So there will be ART facility, either LSE or ART in this. Again, there was a question about deficiency of CD4 kits, viral load kits and testing kits. NACO is taking a very conscious decision to firm up and outsource the supply chain management, introduce barcoding in IMS, have 3 months buffer, and also discuss with the states that in case of shortage, states should buy 3 months drugs from their own stocks, their own funds, state funds. This has already been agreed by some of the states like Gujarat and Karnataka, and they are buying some drugs from their own funds, particularly the single drugs which are a problem. We request you to increase the LSEs. Yes, this is under active consideration. Can treatment be started at LSE plus? As already said, the ART services presently are available at the tertiary level, secondary level, or some sub-district level. But yes, these need to be decentralized. These need to be nearer the patient's residence. These need to be increased. The only issue is initiation of treatment at LSE plus. We need a good trained medical officer of the facility. There are issues about the frequent transfer of these such MOs and their shift duties. The person who is trained on HIV may be on night duty, may be on night off, but there is active consideration how to implement this so that ART can be initiated at LSE plus itself and can be further decentralized also. Some people said that T and ICTC staff are not aware of this policy. I think the circular has been sent, but we need to disseminate this further. Concerns about drug stock, single toxicity. Drug stock, be very careful. You have to be proactive. As you move to treat all, you have to be proactive. You have to use IMS properly. You should fill all dispensations, still the dispensation in IMS to the tune of 70% only. And in case of impending shortages, you send email, make phone calls, be proactive. Rest assured, decision has been taken with careful consideration. Adequate drugs stocks have been ordered in the present tender. The challenge has been uniform distribution across the centers. Having seen this system closely for so many years, we have seen that at a particular center in a particular state, there will be drugs for 3 months, and another center nearby there will be drugs for only 15 days. This uniform distribution across all centers is the responsibility of SACs, and SACs have to take proactive measures to ensure that this is done. Otherwise, this can lead to problems of expiries, overstocking, and other issues. There will be big rush at air centers. I have already again reiterated. These are questions which came again and again, so I put them number of times. 2 months drugs, more LSEs, LSEs at care and support centers, more FARTs, ART in all remaining districts, differentiated care, stable patient. You must have seen in your experience that many of the patients are stable. They just go to doctor who writes repeat treatment and then he goes away. So NACO has now defined stable patients. Listen to this carefully. Stable patients are those patients who are on ART for at least 1 year, have good treatment adherence, have increasing CD4 count, they are devoid of any AOTI. Such patient should be encouraged to get linked to nearest LSE, should be given 2 months of drugs subject to availability of sufficient stocks. This will decongest the center also. This will be helpful for the patient also. Now there was some question on monitoring and reporting. Date of eligibility should be deleted from MLN. Yes, it will be deleted over a period of time. 2.11c of MPR should be deleted. Yes, it will be removed once we basically again do the next version. But very important is all centers should ensure that transfer in and transfer out are registered in the IMS. Again, basically the treatment part of the HIV-TB is captured in 4D section of HIV-TB in the ART reporting monthly format, and it is continuous for the financial year. So I think I have answered to most of the questions. I have not been able to read what questions have been coming in, but I think Divya is going to provide me some questions. I'll try to answer because we have 10 minutes time still left and we'll be able to answer. But as I see here, somebody is writing maintaining unique code. Yes, NACO is going to implement a case-based surveillance over a period of time whereby every person diagnosed positive at ICTC will be given a unique identifier, and that person will be tracked from ICTC to ART center, registration in ART center, initiation of ART and continuation of this, and also on the viral load. Before I answer some of your questions, I have some concerns which basically I would like to again say and show you. You see this is the retention cascade. Over the period of time, this is from April 16 to March 27. If you see total number of people diagnosed, 1,93,000, out of them 1,73,000 got registered, and then there were eligibility initiation of the patient. If you see, there have been losses at each step of this retention cascade. This is not new to you. Most of the people have been trained on retention cascade. And if you see from the total person who were diagnosed, if we start looking at their retention across this cascade, only 44% patients were retained on ART. So out of 100 PLHIV who were diagnosed positive since April 2016, only 44 PLHIV were retained in care. So it is very important that you have to look into this issue, that you don't lose patient, because eligibility is not an issue now. So all patients who are registered should be provided ART and should be retained in care. Also, I would just like to show you very quickly baseline CD4 testing. Still many of the states have got less than 90%, less than 80%, even 66% patient who undergo testing. Eligibility is not important now because most of the people are eligible. Persons who were initiated on antiretroviral therapy, I think this graph is not coming, but national average 89% of patients who were eligible were initiated on ART. 11% patients were still lost. That is why it is important that patient who registered in HIV care should be followed across and initiated on ART. The 12-month retention is a cause of concern, because if you see, many states had got less than 71% retention in care over a period of 12 months, which is a very short period. Some of the states has got even as low as 56%, 51%, 36%, 29% retention in care. This is a very poor retention, and we need to really not only initiate people, prepare them well so that they can be retained over a period of time. Lastly, IMS usage. Only 72% of dispensations are basically recorded in IMS. When we talk of stockouts, we need to actually prevent stockouts. We want to prevent the expiries. It is very important to have a real-time information, and IMS is a very good tool to capture the real-time information on drug stock at the facility level, at the state level, at the national level, and take corrective measures. But if you have a average of 50%, 40%, 60%, 58%, even in one center in state like Haryana, you have 58% dispensation recorded in IMS, which is not acceptable. Again, there is a lot of difference in the consumption of TLE across monthly report and IMS. This may be because of the not being recorded properly in the IMS, and there is as high as 50% to 40% difference between the average being 9%, but many of the centers have got 20, 30, 40% difference in consumption. So I will take up some of the questions. First question is ART suffering from shortage of ART medicine. I think I have taken up this. Patient who has CD4 count done less than 1 month prior, within less than 5 months should undergo fresh. Yes, all patients who had CD4 count not done for last 3 months should undergo a repeat CD4 count, because this will serve as their baseline CD4 count for monitoring response. CPT 250 or 350, I have already answered. It is 350, less than 350 or clinical stage 3 and 4. Doctor not present in many ART center of West Bengal. Yes, that is an issue in some of the states. We will take up this with the State AIDS Control Society. ZLE can be used for renal disease. We have given guideline clearly that it should be Abacavir, Lamivudine, Efavirenz, because most of the patient with advanced renal disease will have anemia also, or will be prone to get anemia. So Zidovudine will not be the preferred drug, rather it will be Abacavir. IPT for how many months? IPT is for 6 months. What is RDT? RDT is a rapid diagnostic test that we use basically for diagnosis of HIV test, the test that we are using presently. Any problem to reduce the drug shortage? Any possible? Yes, I think emphasized this question. That is why I actually said in beginning of my talk that many of the questions will be answered by these questions, because these questions, last 20 slides, came from the field only. So these questions are being repeated again, but anyway, it's my privilege to answer these questions. HR status should be revised. I don't think there is a possibility of revision of HIV HR status. There is a declining funding. There is also a talk of integrating with the health system. We want to integrate with larger health system, get the pharmacists from health system, get the staff nurse from the health system, and not increase the HR. Yes, we need to reduce the crowd. We need to open more centers where there is a crowded center. 2 months dispensation, 3 months dispensation, presently guideline is 2 months, will reduce the burden by half automatically. Can we start IPT for second line patient? Patient, if he has failed on first line ART, if he did not have tuberculosis, he has failed for other reasons, yes, IPT should be started. Should we maintain separate pre-ART ART register? Yes, I said patient should be registered in the pre-ART to begin with, because many of them may not go to ART for various reasons. This is from Gandhi Hospital. We are getting many referrals from ART center who develop renal toxicity. We have only fixed dose combinations available. Yes, the guidelines have been issued that single drugs will be procured by SACS or by Center of Excellence, by SACS providing them with the funds, because it is not possible to procure these drugs at national level because the quantities are very small. Adherence is a big challenge in long-term ART. Yes, it is a big challenge. It is a big challenge even if your CD4 is less than 500. If it is more than 500, yes, it is still a bigger challenge. But that is basically what we need to counsel the patient properly. In future, number of patients from first line to second line to third line will be drastically increased. No, why should it drastically increase if you have got a good adherence? The failure rate over a person who have started on first line antiretroviral therapy are very low. We don't have much of baseline drug resistance. We have patients who have been maintaining their first line treatment for 10 to 12 years to 14 years. So we need to see that the patient maintain good adherence. Is Aadhaar compulsory for accessing ART? I think Aadhaar linkage has been made now compulsory, but I will seek more clarification and get back to you. LFU may increase in this system. LFU happen because patients understanding about the disease and the need for ART is poor. Patient may start treatment, but if he does not understand that it is important for him to continue and not taking drug regularly or not starting ART is going to be very harmful for him. If he is not starting antiretroviral therapy, and there is evidence that antiretroviral therapy even at higher CD4 count provides beneficial effects in terms of reduction of TB incidence and progression to AIDS. So it is a question of how we counsel the patient properly. Additional pharmacist, I have answered this. Then increased drug supply. Yes, drug supply has been taken care of. I don't think there is any shortage of any drug, and now the drugs have been ordered for almost 18 months. Revision in operational guidelines with introduction of ATT and AIPD. Operational guidelines as well as technical guidelines on antiretroviral therapy are being revised now currently. All ICTC may be converted to LSE. Yes, it is a wishful thinking. We would like to definitely convert them to LSE if there is adequate load. Some of the ICTC have just 5 or 10 positive patients, 15 positive patients. But ultimately, yes, ICTC can be converted to LSE if there are significant number of patients already at ICTC. Try to rearrange ART medicine cards. I don't know what you mean by cards. White card if you mean. It is for the SACS to purchase. Do the online patient tracking system. Should do the online patient tracking system. Okay. Let me see some other questions. For INH prophylaxis, what is the duration? It is 6 months. For patient on ZLN regimen treatment failure referred to second line, can we initiate TLE as alternate first line? No, the patient has to be evaluated for second line. Meanwhile, as the person is being evaluated for second line, you have to continue the same regimen. If pyridoxine is not available, to start IPT or not, you should start IPT. Patient can be asked to buy pyridoxine, but then you should ask your state TB officer or district TB officer to make pyridoxine available. Dispensing register will continue along with IMS. For the time being, yes, but NACO has an ambitious plan to move to a paperless ART system. I think the time is getting over. So last slide, my last slide would be, I'll just move on. As in my previous lectures, it's time for introspection also. We should think, sit a while for 2 minutes in a day or in a week, sit together in the group or think alone, are we doing our job well? Can we do it better? I feel there is a scope we can still do better in our jobs, because many of the people are not identifying even the treatment failure when the CD4 counts are available. And we have seen in NASEP and SASEP treatment failures being missed for almost 2 years at a stretch when patient had regular CD4 count. So we can do our job better. Think what more can you do to improve quality of services, as we are committed to 90-90-90 and escalate our fight as we move towards ending AIDS. And 1st December 2016 I had circulated this pledge. We should keep this pledge printout on your table, on your ART center, and work accordingly, that how can we reduce new infection, eliminate new infection among children, and how can we escalate our fight. Let us join hand. We have been working together. You have worked a big deal by achieving 1 million patients on ART. India is the second country in the world to have 1 million, that is 10 lakh patients on ART. But remember, South Africa has got now 3 million. We don't have 3 million HIV infected. We have 2 million, 2.1 million, 21 lakh. So we need to identify and provide antiretroviral therapy to all these 21 lakh. So let us join hands, work together, achieve target and save lives. Thank you and have a nice day. We will try to answer the remaining questions through email to you.
Thank you, sir, for such an informative session. Thanks to all the participants for patient listening. I would request all the participants to kindly enter the e-poll which is going to display on the screen shortly. Thank you once again.